Welcome to the first academic talk of the year. Woo! The Society's doing something. Great! So, as you can tell, this is a day in the life of a clinical psychologist talk. This is Dr. Ollie O'Mara, who's a local, highly specialist clinical psychologist from the local Thames Valley, who's worked in many different NHSs. And yeah, he's going to tell you all about his responsibilities and experiences in his role. Okay, so enjoy the talk.
Hi guys. Can you hear me anyway? So I'm Ollie, clinical psychologist, as James explained. Always nice to start off with, as we do in therapy. Any expectations from the talk today? Anything that people want to get out of it? Don't be shy. Just blank look. So I can literally say anything and you'll be like, yeah, sure. That's fine. Cool. Well, if you have questions, feel free to shout them out during. And if suddenly you go, oh, you didn't cover that, just save it to the end and I'll leave about 10-15 minutes to cover it. Cool. So I work in perinatal mental health and looked after children's services. Perinatal mental health, which is mums that are expecting babies or have just had babies up to the first year of life, so postnatal pressure. Postnatal depression, postnatal OCD, postpartum psychosis, that sort of thing. And then looked after children that have been removed from the care of their parents and placed with foster carers, residential homes, adoptive parents, or grandparents and cases. So interestingly, across both sort of services, quite a lot of trauma. And I won't talk too much about that, but we might touch on it a little bit. I should probably say this talk is from me, so it's not to do with anything to do with TUVI, TZESC and Weir Valley's NHS Trust, so please don't sue me. And nothing to do with the BPS. So this is my view of a day in the life of a clinical psychologist. Cool? Excellent. Let's see. So people are probably wondering about my route into clinical psychology, and if people are thinking about clinical psychology, it normally comes up in talks about what you do. So undergrad at Newcastle, masters in neuropsychology at Oxford Brookes, and then doctorate in clinical psychology in Teesside, just around the corner. Because there's only so many places that do the doctorate in clinical psychology. Durham, interestingly, don't. Newcastle do. And you have to do the doctorate to become a clinical psychologist.
You have to do an MA before you do the doctorate?
No. The way that the clinical psychology scoring all works is that you get so many points to get an interview, and that's dependent on experience, and then masters can give you another point, so to speak, and if you get first, they give you a point, so forth and so forth. So yeah, and I kind of want it to be relevant. But the Masters in Developmental Psychopathology at Durham is very good, actually, so if you're interested in that. Work experience, I was a swimming teacher to start off with, so always useful. And then I was a care assistant in inpatient CAMS. CAMS stands for Child and Adolescent Mental Health Service, so that's 0 to 18. Interestingly, looked after children go 0 to 21 or 25, depending if they're in further education because of development things. Then assistant psychologist in patient CAMS, assistant psychologist to set of outreach, assistant psychologist learning disability forensics, and then research bits across the thing. And that's pretty normal for the type of experience that you need to get on the doctorate. I think it's incredibly rare that you won't get on the doctorate without some sort of research experience or some assistant psychology experience, because again, that scoring system is that's how they look for it to happen. So that sort of makes sense to people. People ask, how long did it take me to get on the doctorate? 3 times. So I took 3 attempts. I got on the reserve list at Leeds to start off with. I got an interview at Oxford second year, and then got on Teesside in my final year. And I've put in a link at the end some helpful resources. The alternative handbook to clinical psychology courses is helpful in trying to decide which route you want to go. But enough about that. So, why clinical psychology? Why did I say why clinical psychology? I've done why not clinical psychology. Why clinical psychology? For me, this is something that they ask you in probably every interview. You might have even asked it of like why psychology in for university. Anyone have any interesting answers? Or just any generic answers? Why psychology for you? Shy group. For me, it was why do people do the things that they do? And particularly in relation to mental health, where some people have resilience and some people get stressed when they're under the same sort of circumstances. So I sort of I was interested in that basically, and sort of fell into it through not being very good at anything else at school or university. So, and the failed rugby career. But what's interesting about why not clinical psychology? Because actually there are lots of different avenues in psychology. Educational psychology is now a doctorate, counselling psychology is a doctorate, forensic psychology is a master's / doctorate now, sports psychology masters, research you can do a PhD, organisational psychology, and they all go into different routes. So if you're interested in children, then why would you choose clinical psychology over educational psychology? If you're interested in just doing therapy, why would you choose clinical psychology over counselling psychology? If you're interested in risk and working in prisons, why would you choose forensic psychology over clinical psychology? Sports, again, are you more interested in working with teams or mental health? But interestingly, for me, clinical psychology underlies a lot of the things that the other areas do, because psychology, and we're going to do something interesting a little bit later. Well, I find it interesting, but and then if you really don't want to do any of that stuff, and don't want to do any further education, just become a life coach, and you don't have to have any qualifications to do that. So you can all describe yourself as life coaches now, but then you are liable against certain things. So always interesting. So I thought I'd take you on the client's journey for if they're coming to see a clinical psychologist. Most clinical psychologists are employed by the NHS. The training route is through the NHS, so if you get on the doctorate, you're also employed by your NHS trust, which for Teesside is Tube, for Newcastle it's Northumbria, Tyne and Wear. Therefore, there's expectation for a clinical psychologist to reduce distress in clients or patients, depending on what you want to call it, sort of new wave of what people want to be called. And there's a sort of expectation, they will see psychologists, they will get therapy, and then they will be better. Reality, never so straightforward. I wish it was that straightforward. I wish sometimes we had a magic wand, but and that's sometimes the expectation of our clients, but that is never the case, because I am not a wizard, as much as I wish I was a wizard. Although I did go to the Harry Potter studios the other week, and that was amazing. So I pretended to be a wizard for a weekend. There's nothing wrong with a 30-plus man pretending to be a wizard. What normally happens in the NHS, and there are lots of clinical psychologists working privately as well, but in the NHS you'll work part of a team, so I work part of the perinatal team or the looked after children's team, and we will get a referral in. And that is usually about reducing psychological stress. So for perinatal mums, it might be along the lines of struggling to bond with baby, and we try and understand that, or it might be around seeing things that aren't there, and we try and make sense of that. For looked after children, it might be trying to make sense of what's happened to them in terms of a trauma framework or an attachment framework, and then we go sort of along into the therapy route. So. What's interesting for clinical psychologists is that we try and formulate slightly differently. So whereas psychiatrists will go down the diagnosis route, we don't necessarily sign up to that framework, because sometimes It's not helpful when people don't fit in boxes. So we try and, again, understand why people do the things they do, and if it's unhelpful, because usually there's a helpful part of the thing that's got them in trouble and why they come to services. So we try and understand what's helpful and maybe when it becomes unhelpful, and then what we can do to exit that. So, assessment, again, why does the person do the things do? I will possibly give them questionnaires. I will always do an interview with them, and sometimes that's structured, sometimes that's semi-structured, sometimes that's not structured at all. And then usually do an observation, and if there's a neuropsychology bent to it, then I'll do some more testing. So again, trying to understand the different layers of which behaviour might occur. So if they've got something going on neurologically, then we want to understand that, and that might be a better explanation of other reasons. But we are looking at the behaviour, thoughts and emotions, basically, after the neuropsychology side of things. And, as all good scientists, we're hypothesis testing at that point. So we're coming up with an idea of why does this person come to me now, and what do they want help with, and therefore I'm going to generate a hypothesis about that, and then I'll probably test it out. So, can you see that? That's a kind of complicated. So have people come across the word formulation before? Some nods, some shades. Formulation is the gold standard of clinical psychology. It's what all clinical psychologists go back to. And it's not unique to clinical psychologists, but it's what they say that they do the best, basically, and try and understand why people do. And this would be similar to psychiatrists, where we offer a psychological formulation, they'll offer psychiatric formulation, and that might be more medical, biological orientated, and ours will be more thoughts, feelings, behaviours orientated. And what we will basically do is go through each of those boxes to understand this is a cognitive behavioural therapy formulation, pretty generic. We sort of want to understand what might start some of the problems, what their early experiences and what that's been done, what their core beliefs are, so how they see themselves. I am a good person or I am a bad person, if we really want to simplify it. And then from that, what rules that they apply to their life. If I'm a bad person, then when I'm in a certain situation, I will act this way. So the shortcuts that we all have in our life to make sense of it. And then what that leads to, and then goes on to think. And then trying to do something productive. So if we have someone that's suicidal, why haven't they committed suicide yet? Which sounds like a very blunt question, but actually we're still interested in it. Different, generic formulation, more systemic. So again, a little bit CBT, but some systemic parts and stories and beliefs that people have about themselves. I can't draw on this, can I? Can I draw anyway?
Yeah, this board here, some pens at the bottom.
Is anyone looking at this side? No. We'll not try and do it in a minute. So, I don't know who came up with this. Can you all sort of see that, even though I've got it really small? Sorry. So, stuff happens in our life, and time happens, because we can't stop time. And so, over time, more stuff happens, and more stuff. And so maybe I start school, and then I finish primary school, I go to secondary school, and maybe I get bullied, maybe I don't. Then I stop secondary school, and then I go to university, and then I stop university, and then I go to another university, and then I go stop university again, and I go to another university, and then my dad says maybe you should get a job. And then gradually over time, I build up a story about my life from all the stuff that happens, because maybe I have a belief about myself that I'm good at sport. And therefore I then go, well actually, I played sport from a really young age and I played rugby. And then I played for another rugby team, and then I went swimming, and then I went skiing, and then I played on a couple more rugby teams, and then I went on tour, and then I started coaching rugby, and then I did a couple more swimming, and I did a couple more races and stuff. And gradually over time I built up this story of my life that I'm good at sport. But what I've then chosen to ignore is the times when I wasn't picked for sport. So the time that I wasn't picked for the cricket team, or the time that actually I wasn't picked for a rugby team, or that I was terrible at football, or that I don't spend it every weekend. And gradually we might change our stories if we want to integrate them into this sort of, into our beliefs, our narrative of how we see our life. What's interesting is when people come to therapy, they maybe have an unhelpful narrative about their life. So for my looked after children, it might be that I'm a bad kid, and therefore they then develop a narrative and pick all the experiences of how they see themselves as a bad person, therefore choosing to ignore when actually they had a really good week at school, or when the foster carer and then bonded really well. But because it doesn't fit, they'll choose to ignore it. Does that sort of make sense? Yeah? So this then goes into how we understand and how we hope. So in therapy, what I'm looking for if I'm doing sort of systemic therapy is some exceptions. So to understand about and try and change some of the narratives. If you want an even more basic formulation, what made you vulnerable, what triggered it, what was the problem, what keeps the problem going? Well, basically understand. So, we're going to think about Henry. So, just in your pairs, you might want to pause this talk actually, I don't know. Come up with some questions about what you would want to, maybe even a little formulation, one of these, about what's going on for Henry, and maybe some questions that you might want to come up with. Cool? So just very basic information, so you can come up with like guesses and stuff. What would be the presenting problem? So why do you think, why is he coming to therapy? Or why is he coming to?
He lost his parents.
Yeah, so there's possibly because he lost his parents. What else?
Because his aunt and uncle want him to.
Yeah. Yeah, what else?
He's showing some antisocial behaviours.
What do you mean by antisocial behaviours?
Aggressive, it's like fighting with his cousin and isolating himself a bit.
Isolating I wouldn't classify as antisocial, but maybe the, although how many people fight with their siblings? Anyone fight? I've got 2 sisters and a brother, and when we grew up, we fought quite a lot. So it's interesting, but yeah, what else?
He's confronting things with his mind.
Yeah? So if a psychiatrist, we might be wondering whether there's any psychosis going on. Now what's interesting is that this is very much aunt and uncle's view, whereas actually if we asked Henry, he might have a completely different view. He might not be bothered by anything, might just want to be left alone. So it's interesting, sometimes we've got different agendas of people coming to reform. We often get different opinion from schools. This kid's a problem, whereas the kid goes, well actually now I'm fine, I'm really enjoying myself, I just don't like the school very much. Predisposing, so what made him more vulnerable to perhaps having low mood, self-isolating, thinking he can control things? Car crash. Yep. So his loss, we know, makes someone more vulnerable. Any other hypothesis about what might make him more vulnerable?
Pressuring off his pet aunt.
What was that?
His aunt and uncle pressuring him into making him like that.
We'll put that a little bit later, but you're on the right sort of lines, like family history of mental health problems, or thinking they can control things. Like, his dad and his mum might have thought the same thing. Some people are smiling at me. Yeah.
Detected his uncle learned how to walk him out.
Yeah. That might be something that keeping the problem going. So predisposing is something that makes someone more vulnerable. So it might be history of mental health, or it might be early life adversity, those sort of things. Precipitating, what do you think has triggered this recent referral?
Oh, yeah, controlling feelings, mind.
Yeah, so a change in behaviour, yeah? So we'd be wondering about why is that started now? Is that an age thing? Is he due to move up to secondary school, or is he is actually aunt and uncle's changing, his cousin moving to secondary school? What's happening in this kid's life or this family's life that they've come to services now? That's what we'd be wondering too. And then maybe what happens around when he thinks that he's controlling things in mind. Is that a particular time of stress? Is that only when he visits zoos? You know. What keeps the problem going, perpetuating? So what do you think is keeping this problem going at the moment? What are some people's hypotheses? Obviously we haven't interviewed the family or anything like that, but...
Maybe he's jealous of his cousin and his auntie and uncle's family.
Yeah. Anything else?
Related to the controlling things in his mind, assuming he's not a wizard, maybe it's...
Let's make no assumptions. Always that.
Maybe it's related to a suppressed guilt. I mean, assuming, well, maybe if he's controlling things, maybe he's controlling events. Maybe he feels that bad things are happening his fault, so he thinks that he's somehow controlling those things into being.
Yeah. So, loss, guilt, difficult emotions. Again, maybe some of his rules for living are a little bit skewed, or his ideas about what's safe are a little bit skewed. Protective, anything protective? Anything good in this kid's life?
So obviously got a family that cares about him.
Yeah. Anything else?
Yeah, he feels he's special.
So that could be helpful and unhelpful. If he's got delusions of grandeur and think that he's walking around thinking he's got something, he might get himself in trouble. But actually, if it's protective, I am unique, like we all are, then that might be some sort of part of his resilience.
He's being referred to the service, so he can now seek help or be given help because he's with.
Yeah. It's always a really sad thing, and it often happens of when we've got protective stuff that they go, well, at least they're referred in, and you go, oh no, it's like the only good thing they've got going for them. You start to feel a little bit sad. Plan. Any plan for this family? What would you want to do with this family?
You need to get individual accounts of him and maybe individual of the aunt.
Yeah. So we want everyone's point of view. Yeah, and maybe we might do family therapy with them if that's what's becoming involves the cousin a little bit, or we could just send it to Hogwarts and take him away from this horrible family. So either way, I did this task and used Henry in a different thing and with a different role play, and a couple of people really struggled to let go that it was Harry Potter. They went, yeah, but we know what Harry Potter life is like, and this is not it, and he needs to go to Hogwarts, and I can't let go of anything else. It's just role playing, just trying to make it. No, he needs to go to Hogwarts. Okay, you can go to Hogwarts then. And actually, that is sometimes interesting. If like sometimes we try and fix because we never actually want to. Fixing is not the right. It suggests that something's wrong. But sometimes we try and help a family by keeping them all together, and sometimes that's not the solution. Sometimes the risk is too great, and actually we do need to intervene. But that's more social services thing. So different. Thing. So this is from NTW, which I've just stolen off Google because it came up. And what we can see now is a slightly more complicated formulation of what's troubling someone at the moment. So if their presenting problem is fear, rage, depression, whatever that means to them, and then what their previous experience is like, what's becoming a problem at the moment in terms of flashbacks, and then resources. So similar sort of thing about trying to understand everything that's going on. Psychotherapy.
Dr. Switzer?
Yes, come in. I'm just washing my hands.
I'm Catherine Bigman. Janet Carlisle referred me.
Oh, yes. You're alive.
Yes, that's me. Should I lay down?
Oh, no, don't do that anymore. Just have to. And let me tell you a bit about our billing. I charge $5 for the first 5 minutes. And then absolutely nothing after that. How does that sound?
That sounds great. Too good to be true, as a matter of fact.
Well, I can almost guarantee you that our session won't last the full 5 minutes. Now, we don't do any insurance billing, so you would either have to pay in cash or by check.
Wow, okay.
And I don't make change.
All right.
Go.
Go.
Well,
What?
Tell me about the problem that you wish to address.
Okay. Well, I have this fear of being buried alive in a box. I start thinking about being buried alive, and I begin to panic.
Has anyone ever tried to bury you alive in a box?
No, but truly thinking about it does make my life horrible. I mean, I can't go through tunnels or be in an elevator or in a house, anything boxy.
So what you're saying is you're claustrophobic.
Yes, that's it.
All right, well, let's go, Catherine. I'm going to say 2 words to you right now. I want you to listen to them very, very carefully. Then I want you to take them out of the office with you and incorporate them into your life.
Shall I write them down?
Well, if it makes you comfortable, it's just 2 words. We find most people can remember them.
Okay.
You ready?
Yes.
Okay, you're there. Stop it!
Stop it?
Yes, S-T-O-P, new word, I-T.
So, what are you saying?
You know, it's funny. I say 2 simple words, and I cannot tell you the amount of people who say exactly the same thing you're saying. I mean, this is not Yiddish, Catherine. This is English. Stop it.
So, I should just stop it.
There you go. I mean, you don't want to go through life being scared of being buried alive in a box, do you? I mean, that sounds frightening.
Yes.
Stop it!
I can't. I mean, it's been with me since childhood.
No, we don't go there. Just stop.
So I should just stop being afraid of being very loud in the house.
You got it. Good girl. Well, it's only been 3 minutes, so that will be $3.
Actually, I only have a 5, so
Well, I don't make change.
I guess I'll take the full 5 minutes.
Fine. All right. Well, what other problems would you like to address?
Whew. I'm bulimic. I stick my fingers down my throat.
Stop it! Not of some kind? Don't do that.
But I'm compelled to. My mom used to call me fat.
No, we don't go there.
But
No, we don't go there either.
but my horoscope did say.
We definitely don't do that. Yes, stop it. What else?
Well, I have self-destructive relationships with him.
Stop it! You want to be with a man, don't you?
Mm-hmm. Yes.
Well, then stop it. Don't be such a big baby.
I wash my hands a lot.
Sorry. I wash my hands all the time. A lot of germs. Yeah, don't worry about that.
I'm afraid to drive.
Well, stop it! How are you going to get around? Get in the car and drive, you kook. Stop it!
Stop it! You stop it!
What's the problem?
I don't like this. I don't like this therapy at all. You're just telling me to stop it.
And you don't like it?
No, I don't.
So you think we're moving too fast, is that it?
Yes. Yes, I do.
All right, then let me give you 10 words that I think will clear everything up for you. You want to get a pad and a pencil for this one?
Right.
You ready? Right, here are the 10 words. Stop it or I'll bury you alive in a box!
Basic therapy. So we don't do that. Well, some really bad CBT therapists didn't say that. But interestingly, psychology, you do end up doing a bit of therapy, but I do know psychologists that don't do any therapy whatsoever. And then neuropsychologists that just do assessment. I know people that work in probation that just do formulation, so try and understand. So actually, if you want to be a therapist, don't become a clinical psychologist. It's probably one of the first things they tell you on clinical psychology doctorate training. There are lots of routes to become a therapist, and you don't need to be a clinical psychologist to be a therapist. So it takes a lot less time, a lot less money, a lot less effort to just go down. And if you can then come any one of these, I've even given you loads. I don't even know what some of these are. I know what most of them are. But, and you don't need to be a clinical psychologist. You can be a nurse, or you can just go into improving access to psychological therapies and do your therapy training that way, or social work, or counselling psychology. So again, it's trying to understand why clinical psychology is the route that you would want to go into. After my clinical training in some during, I trained in these sort of therapies. And that's what sort of fits with my client group. But I know friends that have and colleagues that have trained in lots of these that they find interestingly useful. Depends on which ones evidenced and researched and accredited. So actually stuff like NLP isn't governed by any sort of therapy, whereas the rest of them are. So you have to be careful. So if you ever go into therapy, make sure that it's with an accredited person that can show you their qualifications, show you who they're governed by. Otherwise, you can end up with someone that's dangerous. The reason that I like clinical psychology, though, and sort of what I use, is that I can use all these therapies and I might use them integratively, and I've got my formulation and I've got my layers of understanding, and everything that I do is based in research and is based on theory. And that's what sort of makes a difference. So, to raise another point, let's do this one. I was thinking about my undergrad and how useful my undergrad was to my clinical psychology training. And before I started my clinical psychology training, I thought, I don't think I'm going to use anything from my undergrad to think, but actually I do. And then I remember sort of thinking, because like, it's experimental psychology at Durham, isn't it? Or along that sort of line? Yeah. So you do lots of core subjects, so like perception and memory and everything like that. Is that sort of right? And it can sort of be like, well, how's this going to apply to working with distress? Memory really applies, especially if you go into neuropsychology, and actually memory really applies if you're working with trauma, because how do traumatic memories get processed differently from generic memories and stuff. But we'll watch this, and this hopefully will be some of the stuff that you learn in your undergrad course, and then I'll explain how I use it in therapy with my clients. Has anyone come across ASAP science? I'm a little bit of a YouTube geek.
You may not realize it, but your brain actually processes information in two very distinct ways. Like when you look at this photo, you instantly know she has blonde hair, is visibly angry, and likely has some choice words to yell. Without any effort, you experienced fast thinking. But if you look at the following problem, something different happens. Sure, you immediately know it's a multiplication problem, and you knew you could solve it if you had the energy, but didn't. If you do try, your muscles will tense, your pupils will dilate, and your heart rate will increase. Now, you've experienced slow thinking. These two systems of fast and slow thinking dictate much of our perception and reaction in life. Take these lines, for example. It's clear that they're different lengths, but if you measure them, they're actually the exact same length. Even now that you know, System 1, or your fast thinking, can't stop seeing the illusion because it acts automatically. A similar effect is seen here. Which figure is the largest? Again, they're all the same size, but the suggestion of perspective and depth causes your System 1 to interpret the picture as three-dimensional, even though it's on a flat two-dimensional surface. It's making quick work of the available information, and so your conscious System 2, or slow thinking, must compensate after the fact and choose not to believe your intuition or instinct. Want to see your System 2 in action? I'll show you a string of 4 digits, you read them aloud, then add 1 to each of the original digits. If the card reads 3795, the correct response would be 4806. We'll then go to the next card and you'll do the same, followed by the next card. Ready? Go. Few people can cope with more than 4 digits, but even harder is add 3. The interesting bit is that though your pupils would have dilated, you often become effectively blind when you fully engage System 2. Did you notice the color of the text change? Or how about the fact that the numbers completely changed when I put them off to the side? Listen to the following puzzle. A bat and a ball cost $1.10. The bat cost $1 more than the ball. How much does the ball cost? Chances are your System 1 intuition was yelling 10 cents. But this appealing System 1 answer we know is wrong. In fact, the correct answer is 5 cents. Even if you worked out the correct answer, you likely thought of 10 cents along the way. System 1 is trying to work out an answer as quickly and seamlessly as possible, which is extremely beneficial in everyday life. If every activity required full mental effort, it would be exhausting. But knowing this allows us to understand that not all of our first impressions are correct. How many animals of each kind did Moses take into the ark? So few people detect what is wrong with this question that it's been dubbed the Moses illusion. In fact, Moses took no animals, Noah did, Again, our brain invests as little resources as necessary so that things run quickly and smoothly. Because Moses is not abnormal in the biblical context, System 1 unconsciously detects an association between Moses and Ark and quickly accepts the question. In a similar way, System 1 generates context without you knowing. Reading each of the following may seem fairly simple. A, B, C, Anne approached the bank, and 12, 13, 14. But your brain actually interpreted these ambiguous statements without you ever knowing. You could have read it as A, 13C, or 12, B, 14, but your brain created the context unconsciously. Also, you likely imagined a woman with money on her mind walking towards a building with tellers. But if the sentence before this was, they were floating gently down the river, the entire scene would have changed because bank is no longer associated with money. Without an explicit context, System 1 quickly generates one based on previous experience. In this case, you've likely visited more banks than rivers, and so the context is resolved accordingly. This ties into a concept called priming. For example, if I said wash, how would you complete this word fragment? Most would see soap, but had I just shown you the word eat, you'd be more likely to see soup. In this way, both eat and wash prime your thoughts. Though System 2 likes to think that it's in charge and knows what's going on, the truth is that priming effects have even been shown to affect and modify behavior. These arise in System 1, and you have no conscious access to them. If you'd like to learn more about the thinking systems in your brain, check out the book Thinking Fast and Slow by Daniel Kahneman, which covers it in great detail. I'll put a link in the description which you can check out. Got a burning question you want answered? Ask it in the comment.
Cool. Is that on your reading list at all? Yeah. Good. So the couple of things from that. One of the things was the fast thinking is similar to sort of the narrative stuff. So we create a shortcut in our brain to make sense of the world, and sometimes that shortcut's helpful and sometimes that shortcut's unhelpful. So sometimes in therapy it's about slowing things down to understand what are the negative automatic thoughts, if you want to think about that way, or shortcuts or narratives that people have come up with that possibly have been unhelpful. Priming is another example, is that we know that depressed people, if you're thinking negatively, you're more likely to see the negative outcome in things, or that sort of fast thing. So again, similarly, we then try and slow things down and try and help them recognise things a little bit differently. So undergrad psychology being applied to therapy. Good. The last thing after we've done therapy, we want to know whether it's been helpful. And again, we go back to questionnaires, observation, interview. And it's the hardest thing to do in therapy is how was it helpful? So what did you do? And this is where research comes in really helpful to show actually what it is that is helpful, and asking the person what did they do differently. And this is where some of the more psychodynamic therapies fall down, because they can't always say what happened. Just something changed a little bit. What was it? Not too sure, but things have improved. Yeah, but what? I don't really know. And so that's why sometimes we get more funding for things like cognitive behavioural therapy versus psychodynamic, even though efficacy is pretty similar. The other thing around evaluation is that we're in a currently challenging, changing NHS that is looking for productivity and showing that you're worthwhile at your job. So actually you have to show that you can do what you say. So that was our therapy journey, and then while they've done the assessment and the formulation and therapy and the evaluation, behind that there's a whole other load of things that I do. Teamwork is one of the big things. Leadership, so being one of the more senior members of the team and deciding where you're going to go. I supervise all my members of my perinatal team, apart from my psychiatrist, and some of the members that looked after children's team, and then offer it to social services as well. I attend loads of meetings and other meetings and more meetings. And then also I'm thinking, like, how am I going to develop services? And again, psychological theory comes in there. So actually fast thinking, if I've got difficulties in supervision or difficulties within the team, I'm trying to understand maybe what shortcuts they're implying, or inferring in their life to actually mean that some things are not quite working. And then I'm also looking at team dynamics and everything like that to understand. And then behind all that is still doing research, because that's the most important part, and that's why we do a doctorate, because actually we want those skills in research to carry on doing it. So lots of my colleagues have done PhDs before doing their doctorate, so they're doctor. And it's something that the NHS really needs, and something that's really challenging for clinical psychologists when they've got a caseload of 100 and still then trying to do that other research. So, type of person that makes a good clinical psychologist, leader, scientist. I'm sorry that I put all men on there. I was aware of that after I did it, and then I didn't have time to change it. Listener, curiosity, and a little bit like chefs, so picking ingredients from everything. And the only thing that I didn't put on there was detective, which is what I think that curiosity is about. But an empathic detective, so maybe not Sherlock Holmes, maybe slightly more Watson-esque, but yeah. If you are thinking about doing clinical psychology, things are changing. Whereas before, the doctorate was always funded for clinical psychologists, which made it really attractive, but super competitive. That's going to be changing, I think, and at the moment, I think next year's guaranteed. The year after, I think they're going to cut the funding, change it to a bursary sort of scheme. So it's going to change. The NHS is changing, privatising and everything, and coming out of the EU will have a massive impact. So it's going to be tough, but interesting and challenging. And actually, the grounding in psychological theory means that clinical psychologists are really well placed to influence that in a positive way. Some resources, alternative, Big Yes is the best. ClinSci, if you haven't been on ClinSci, don't go on it. It is helpful in a lot of ways. I never went on it, but I know a lot of colleagues and people that did. Well, I went on it once and realised that there's lots of neurotic people asking lots of questions. Why didn't I get on the clinical course? So it's helpful for some, but take it with a pinch of salt and see whether it's helpful for you. Because if you're really neurotic, then maybe it's not going to be that helpful for you. So again. And I've finished. Pretty sort of time. So we can stay for like 5-10 minutes of questions. But yeah, that's me done. Cool. Any questions?
If you do a doctorate in the UK for clinical psychology, what are the opportunities for example, if you want to move abroad and perhaps practice there?
It doesn't transfer over to America, but it does transfer over to Australia and New Zealand. And then I'm not too sure about other countries. I think France, I think some of the Canada, I don't think it transfers. I think you might need to do another exam out there. Similarly, if you're training in Canada or America, you can sometimes do an exam over here. But yeah, like Netherlands, it might transfer over to and stuff like that. Yeah, at the back.
How hard is it to get on the doctorate?
Yeah, really hard. It is. It's ridiculous. Unfairly hard. I mean, it sort of works in terms of the point of you accumulate enough experience and you give yourself a really good opportunity of getting an interview, because actually you do score that high, but you've got to realise that people are doing the same thing. And actually what's almost harder to get on the doctorate is getting an assistant post, because they're really rare. And lots of them are, some of them are unpaid, which is ridiculous and shouldn't be the way it is. Saying that, do voluntary assistant scheme, as do James Cook and North Tees, I think, do voluntary assistant schemes. So there's lots of chance to get experience out there, but then it just completely biased. If all my assistant posts were paid, I couldn't have done them otherwise. So it's all biased towards the more privileged. But yeah, so it's thinking about what the Clearinghouse, ClinSci and the Alternative Handbook say what the percent ratio is for applicants. So I think for most of them it can be anything from 70 to 1, like 70 applicants for one place to 200 to 1. And then that's the same for assistant posts. So it's highly competitive, which makes it an interesting profession to work in terms of how competitive people are. Interesting, that's not that helpful a trait to have, because if you're really competitive and narcissistic, you don't end up being a very good psychologist or empathic. So interesting dichotomy.
How many years of experience did you have before you did the doctorate?
Before I did the doctorate would be 4 or 5. Question over there?
Yeah, I was just going to ask, how many years did it take you to get to the position you're in after your doctorate, or did it just happen straight away?
How do you mean?
After getting your doctorate, did you go straight into getting a job, or was it like quite hard to get there?
No, it's pretty. We're in a quite fortunate position that because we're so well trained, that there are quite a few job opportunities. 100% ratio of conversion to jobs. So that will obviously probably change as the future, like as more clinical psychologists get trained. But actually, we're quite a good profession in evidencing why we're good.
Yeah.
We should be better at it, and some would say we're underpaid for what we do, but just compared to psychiatrists. I actually do like psychiatrists, and it's coming across that I don't, but they are very good. Also, we sort of, we're quite hopefully quite innovative thinkers, which again is something different if you just want to be just a therapist, but clinical psychology, you've got to be a little bit innovative and therefore developing services. So my perinatal post was 2 days, and is now going to 5 days. So they're going to employ another psychologist for that. Similarly, I looked after children, sort of thing. So you've got evidence how good you are and how you're worthwhile.
If you weren't a clinical psychologist, what other field do you reckon you would have gone into?
Teacher, probably.
Teacher?
Yeah, probably. I don't know whether I would have gone down. I might have done counselling psychology. Counselling psychology you have to pay for yourself, so I don't think I would have been able to afford it. So I probably would have gone down research and teaching or something.
What do you know about counselling psychology as a
Doctorate is very good. It's the research string. It isn't as strong. So it's very similar to the clinical psychology course, but with a different emphasis on the type of therapy that they promote. So whereas you would say clinical psychology probably fall down more on the cognitive behavioural therapy systemic, whereas the counselling go more towards the humanist, sort of Rogers and people. So they are probably slightly more, possibly psychodynamic underneath. And you have to do your own therapy and counselling as well, like have your own therapy, whereas clinical you don't. And the research is, you still have to complete a doctorate, but I'm not too sure about the comparison in terms of strength of the doctorate, not strength, but strength of research, so whether it's harder to do. So it's, might want to invite a counselling psychologist along to...
We've got one booked for next term.
There you go. So they'll probably be completely different views of rubbish clinical psychology. But actually counselling psychology, I've got some excellent counselling psychologists that I work with. Yeah.
If you were looking to go down the master's route, how much would you say the relevancy of the master's has on, for example, getting maybe the opportunity to get an interview in clinical psychology?
We obviously have to be relevant.
Yeah,
but I think the research skills, so if your research isn't as strong, then it's a really useful to develop that skill in terms of master's level and writing and everything. Relevant in psychology, obviously, I wouldn't go off too far. Brain sciences might be interesting. But they don't say that you need to do one to get on the doctorate. You can have enough experience otherwise. It depends how strong your undergrad was.
You come, when you talk about your role, it comes across that you just do a lot of research and that you don't really have as much interaction with people as much as I thought you would. And you also said that if you want to be a therapist, then, or you want to deliver any kind of therapy, then you should be a clinical psychologist. So, what do you actually do? Do you just do you do the formulation like you said, and is that it? Is that as much as your role goes, or do you also?
No. So yeah, I probably misled you a little bit. I do loads of therapy. If I have 37.5 hours in my week, what I'm supposed to be employed for, but technically I probably work about 50 hours, I probably see, so I've seen 6 people for therapy today, and I probably see on average 4 or 5 for individual therapy or systemic therapy. I'll chuck in a couple of consultations around formulation and stuff and people trying to understand, so meetings at school and stuff. I'll have 2 supervisions a week, adding a couple more meetings. Interestingly, I sold the research because that's what hopefully slightly unique about clinical psychologists of carrying on doing that. But that's the thing that's hardest to find time for, although we're collecting a lot of data in terms of assessment and intervention. So it's probably the majority of my work is more therapy. The reason I said that if you want to just be a therapist, there's just a lot easier routes than just doing the clinical psychology sort of thing. So actually, clinical psychology gives you training in lots of different other things as well, like research, like neuropsychology assessment, like everything. Whereas actually, if you just want to sit and talk to people, not that therapy's not just quite like that, then there are different routes that you can go down. That makes sense?
Makes sense. Also, in your role, do you ever incorporate what their medication they're taking and think about things like that, or is that do they also have a psychiatrist who kind of deals with that, and how do you interact with a psychiatrist?
Yeah. So the majority of my perinatal mums will have a psychiatrist, and then maybe a third of my looked after children will have a psychiatrist. And it will come in terms of formulation about what interaction the medication is. So if they're on benzodiazepines, then I might not do EMDR, high movement desensitization reprocessing, trauma, because that's just sedating them rather than helping them experience some of the stuff that they need to relive to process it. And then I will have, so when I talk about my meetings, I'll see a psychiatrist every day, have a chat and formulate and work out what the best plan is. And then obviously it's really bad of me, I didn't talk about all my other people that I'm in a profession with. So I work with nurses, social workers, teachers, occupational therapists, physiotherapists, and we all work as a multidisciplinary team to give the best package of care to the young person or mum or the family. So yeah, there's loads of, hence why I put the team working is the majority of work, and if you're not a team player, again goes back to therapy can just be very singular and you can just see someone come in and go out and that's it. But when you're working in the NHS, you've got loads of other people that you need to interact with. Does that make sense?
Fantastic, thank you very much.